talking to Sabrina Fabi about her article on cellulite, patient selection and combination treatments for optimal results, a review and our experience. This has been published in Dermatologic Surgery Journal. And let's just start, Sabrina, with if you could give me a basic definition of cellulite.
So cellulite is something where you're going to see a lot of different definitions. And I think it's because we lump many things into one. If you look at Mitch Goldman's chapter on cellulite, he describes it as liposclerosis or edematofibrosis. But essentially, when you visually see it, it's an undulation of the skin with a lot of skin surface irregularity, mainly categorized by dimples, but the other part can be a component of skin laxity. And I think that that's generally the reason why one modality doesn't address all of it, because you are lumping multiple definitions into one term.
You discussed a couple of different theories on pathogenesis. Do you think all of these are at play? Do you think one predominates? Do you think the pathogenesis is different by patient and age?
I do. So I think that there's definitely a multifactorial component to why we see cellulite. There's no doubt that there is either a genetic and possibly and probably definitely a hormonal role that plays in the development of cellulite, because we classically see it in women that are beyond puberty. We don't see it in adolescent women or children because there's probably an element of hormones. The very reason why we may see it in a neonate right when they're born, because of that surge in their mother's estrogen that still remains. We also know that when you're premenopausal, you see cellulite typically in the outer thighs and buttock, where that shifts into the abdomen once you go into menopause, again, because certain receptors, like Kahn et al. Showed in their JAD publication in 2010, showed that certain receptors turn on and off as a function of age for hormones. So there's an age, genetic, and also hormonal element. And from Sebastian's Cotofono's most recent work, we know that the framework of collagen that essentially runs through the fibrous septae that make up the fibrous septae in our fat plane is different from males and females. And he's shown that very beautifully. And so the architecture is different. So it's also an architectural difference that exists. So I think all of these things are at play. The very reason why we can't address cellulite with just one modality.
So it's a very complete review, and one portion of it you talk about topicals for cellulite.
Yeah.
Do you use topicals?
So somebody comes into my office wanting a cellulite treatment. Generally, for the most part, needs a combination of things, whether it's to release or subside the dimples, but also tighten the skin. And we know as dermatologists that retinols are the gold standard in stimulating new collagen production. Is it going to make their cellulite go away? Absolutely not. Can it address one component of cellulite, which is dermal thinning? Absolutely. But is it going to make it all look better? No. I think it's just an adjunct if you want to do something at home to add to your result. And there was one trial where patients were prescribed this for their cellulite twice a day for 3 months, and they did see a difference that was significant, but it did not make their cellulite go away.
That was a retinol?
And that was a retinol.
And was there a retinoid reaction at all, a significant component?
No, there wasn't. In my practice, because the skin of the buttock and thigh luckily is generally a bit thicker, and it's not in a sun-exposed area unless you're in maybe San Diego. So for the most part, patients tolerate it fine in those particular areas. For my patients, I do like them to use typically more of a prescription grade tretinoin and like a hyaluronic acid based maybe lotion that they can apply in those areas. So like one tube can at least get them maybe about 6 months of a result.
Do you get something compounded?
There is one that's commercially available,
okay.
And that's what I use.
All right. You were careful in your review of radiofrequency devices used for cellulite. It seems like the evidence is not strong and the amount of improvement minimal, and it seems like you've had better results with microfocus ultrasound. Is this the device that you feel like has more reliable positive outcomes? Perhaps you could give me some insight on that.
So I guess for the patient that comes in, For a dimple, for me, there's no better treatment than controlled subcision with a vacuum-assisted device. I tell my patients in those instances, I can probably improve 90% of your dimples by 50%. And that's what Bill Coleman and Michael Kaminer showed in one of their trials, and even presented here in their 5-year in the 5-year data that they presented. So that's probably the most consistent result that I can get. But that's dimples, and dimples only really make up one element of cellulite. After the age of 30, there's an absolute skin laxity component to cellulite. Patients come in thinking it's the same thing and it can be addressed with controlled subcision, but it can't. It can actually make it worse, especially if you're treating along the gluteal crease, where if you release some of those ligaments, you can actually drop the buttock and make it look longer and less attractive. So in those instances, I do like to use a skin tightening or skin lifting modality. In that space, it's very hard because none of these are surgical treatments. And so monopolar radiofrequency, there is one monopolar radiofrequency device with vibration that is approved for the temporary improvement of cellulite. And we have that modality. I haven't seen as much improvement with it as I've seen with microfocus ultrasound. But again, as with everything we do, it's dependent on dose if you're using injectables, or how many pulses and what energy you're treating with when you're using some of these devices. So we've published on its use for the buttock, and in that publication we go over the treatment paradigm. So how many lines you have to deliver over a surface area to get consistent results. But that'll only address, I'd say, the laxity component no more than, I'd say to my patients, 30%. So you're still left, maybe dimples can be improved by 50%, your laxity can be improved by about 30% on a good day. You're still not 100%. And so that's where you have to be honest with your patient, because there will be the camp that will do anything, and that's fair. But then there's going to be the camp that's like, well, if you can't get rid of all of it, then it's not worth my time and my money. So as long as you're honest about it, you'll be surprised how many people are going to still, engage in the journey with you.
So this might be a good time for you to walk me through a patient consultation, and if you want, maybe use a couple different patient types, because I'm guessing that what you have to say to a young patient where it's mostly dimpling might be different than what you would say to an older patient. And how do you talk to them about those different components, the percentage improvement, and setting their expectations?
Yes. So nothing speaks better than a photograph. So when I do my consultation, I verbalize this, but all with photos to demonstrate what I'm trying to say. So I'll show them, in a 20-year-old, generally it's a dimple issue, luckily. And so they're an excellent candidate. In my hands, what I recommend is vacuum-assisted subcision, controlled subcision. Doris Hexel has published on using a no-core needle to subcise. So you can use whatever you feel most comfortable with. And I'll tell them that I can get 90% of these dimples improved by about 50%. And that result has been shown to last at least 5 years. If you want added improvement, I won't even consider doing another treatment until at least 6 months, because we know from Coleman and Kaminer's work that the results continue to improve over time. And because there's still a lot of induration after that subcision, and so I don't want to traumatize them again.
I'm sorry, do you find that you're doing liposuction at the time of subcision? Yeah.
So it's an N of 1, but in our practice we had a case of lipo with controlled subcision and someone developing a seroma. And so I'd be careful to do lipo and controlled subcision at the same time. Now, even though your lipo is going to probably be more deep than that, I would just caution, if you want to minimize your adverse events, keep your patients satisfied, then maybe stage them is what I would say, because the controlled subcision is, in my hands, a 30-minute procedure. It's so quick. I use a Klein pump to infill, which takes 5 minutes, and then I release in 10 minutes. What takes 15 minutes is the photos, getting them in standardized lighting. And that's the key. If you're going to embark on any of these treatments, don't even bother if you don't have some type of standardized photographs to take with a black backdrop as well as an overhead light, so that you can really capture those cellulite dimples. Because Doris has also shown, if you change the lighting, you can make those dimples go away. So lighting is everything. So I answered one part of your question, which is the 20-year-old, but that's not the reality because many of these patients can't sometimes afford these modalities. And so when you go into more of like 30-year-old and greater, they call it cellulite, but there's lumps, bumps, there might be excess fat. So in those patients, I always address the fat first. I'll either do lipo or I'll do cryolipolysis. That's my non-surgical choice for reducing fat non-surgically. Once I've done that, I at least wait 1 month before I do a skin tightening procedure. But if I'm doing controlled subcision, I'll do it on the same day. So I'll do the cryolipolysis first, and immediately after, I will do controlled subcision on the same day in that patient, and we have not seen an increased incidence of adverse events. Then I'll stage them, and if they have an element of skin laxity, then I tell them to come back at least a month later, and then I'll do microfocused ultrasound.
Great. You had sort of a really nice algorithm in your article for different types of cellulite and how you order the treatments, and you've touched on that somewhat already. Was there anything else you wanted to add to what you say as far as sequencing issues?
No, I think probably the key thing with any of it is the realistic expectation. Because cellulite has had a negative connotation, I think, in the minds of many consumers, because there's a lot out there claiming that it can get rid of the cellulite from a topical with some caffeine to it, to devices that you have to do twice a week for 16 weeks to maybe get temporary improvement of about 50% that goes away. So there's such a spectrum out there that you have to just be really honest. So for me, what's worked are photos, really showing this is a dimple that can be treated here. This is laxity that can be addressed here. And even if I address your laxity, it's only 20 to 30% improvement. Are you going to be happy with that? Then they want to see a photo of what 20 to 30% improvement looks like. Then I show them that. 50% of people are okay with it. 50% of people don't want to waste their time. And then I tell them your alternative is what? A butt lift? Because it's like you can't even do, like you can do an anterior thigh lift, maybe for what people perceive as cellulite in the anterior thigh. That's an area where I would not do controlled subcision. That's a laxity issue. So there I'll either do microfocus ultrasound, and if they need some added help, I'll even do an injectable biostimulator. So there I'll either use diluted PLLA at a 16 cc reconstitution, or I'll do diluted calcium hydroxyl apatite, typically 1 to 2 or 1 to 3 in dilution. And that I'll spread out at minimum 2 months apart. So I don't even have them come back until at least 2 months later, and we may do another session. So then they have to really think, is this something that's a lot of money at that point, you know? Some folks are willing to do it. Others, it's not worth it.
That's such a good point about the anterior thigh.
Yes.
Because you definitely see those patients. I've heard mention at times in articles about cellulite in the abdomen, and I don't feel like that's an area that has what I would call cellulite, but what do you feel about that area?
Right, you're right. So that in that con paper where they talked about how you get cellulite in the abdomen, I have seen it in some men that are even on estrogen therapy for their prostate cancer. You get like this waviness or undulation, but I agree with you that it's not an area where I necessarily be quick to like subsize some of those fibrous bands. Truthfully, I haven't been put in a place where I have to treat that. That's not an area where people come in complaining about as much as what they perceive inner arm. Like the medial arm, a lot of people think that's cellulite, and it's that kind of similar like waviness that you get. In that area, I definitely would not subsize. Microfocused ultrasound, I have not had as consistent of a result in this area. It can be actually quite painful. So this is an area where I do like dilute calcium hydroxyl apatite. So different areas require different modalities, and modalities are not going to have the same efficacy because it's different tissue. And I think as dermatologists, there's no one better equipped to know how to assess these different areas because we understand the skin. We know the pathophysiologic changes that can occur in different areas as a function of age, and we know all these modalities. Some of us have even helped develop and invent them. So you can then actually use different modalities for different areas.
With the injectable biostimulators, is there one or two areas that you think it works best on?
Yes. For me, the inner arm is a home run. That, for whatever reason, is an area that it works in the best on. And there is a publication, I can't recall the author, but that's been published on.
And how many treatments usually?
I usually do 3 treatments, and I space them 2 months apart. But if you look at the literature, there's a great paper by Yana, killing her last name, so I'm not going to even say it. She's a dermatologist from Russia, where she saw that you really took at least you still had high levels of collagen type 3 at 4 months after 1 injection. And then at 9 months, it was finally converted all to collagen type 1. So it takes that long from an injectable biostimulator to really convert everything to collagen type 1. So I would say if we even spaced it every 4 months, we may be able to, the patient will continue to see improvement, but we may be able to optimize from our last treatment and not have to do so many treatments. I think the time interval has to be decided. I don't think we know yet, and the companies have to do a better job of doing the trials for us to tell us what's the optimal interval on the body, may be different than the face, just because we don't have the same circulation, so we don't have the same influx of macrophages to kind of help stimulate fibroblasts to create new collagen. So I think it might be slower on the body. So I've been leaning more to even 4 months. I tell my patients, come back and we'll do another session. But 3 sessions is what I tell them.
And the same amount, either
1 to 2 or 1 to 3, depending on skin thickness.
Okay.
And in Yana's paper, she found that there was no statistically significant difference in neocollagenesis if she'd use 1 to 2, 1 to 4, 1 to 6 with diluted calcium hydroxyapatite. Gabriela Casabono showed that 1 to 1 was the optimal. So Yana didn't do 1 to 1, so there may have been, but once you hit 1 to 2, 1 to 4, and 1 to 6, it was about the same. So maybe 1 to 1 is optimal, but in my experience, you have to be careful in areas like the inner arm, because maybe someone with thicker skin, it can be forgiving, but someone with thinner skin, you may see like a white opaque material. You will see it. And some patients get a little nervous, others don't mind because it reflects light and looks a little younger.
A lot of developments have happened in the last 10 years, as you point out. Do you foresee any major changes in the treatment of cellulite over the coming years, or will the pace of discovery slow down?
I don't think so. I think people are definitely looking into this because almost 90% of women are affected by this condition. It's not just 50% of us. Even a thin patient can have cellulite. So, and it starts after you go through puberty. So it's an extremely large age spectrum that is experiencing cellulite. So, we know, and I participated in a trial, and the results which were presented here at the ASDS 2019 of an injectable that does break up in lice the fibroceptae. So instead of mechanically doing it with controlled subcision, now you're doing it with an injectable formulation. In that trial, about 70% of subjects noted a 1-point improvement. Now, is that enough to maybe, have patients want to embark on this journey? I think it's going to probably determine what the cost is. It's probably going to determine whether people decide to do it. But what's positive about it is that a doctor doesn't need capital equipment, and the patient can just basically get injected in a 5-minute visit in an office and see an improvement. And right now, the long-term clinical trial is going on for 5 years to see how long that result will last. But I believe, just like we've seen with controlled subcision, if you lice the bands are lysed. Can someone still develop more cellulite dimples? Yes, but at least those dimples will probably remain improved.
Finally, are any of the devices mentioned in your article considered safe for non-physician use?
So non-physician use is a very broad spectrum because depending on where you are in the country, an engineer in North Carolina can administer treatments like microfocused ultrasound, or an esthetician in Las Vegas. And so I think that the consumer has to be aware that not all of us have the same level of training. Just because you offer a treatment doesn't mean that you have gone through 13 years of undergraduate medical school and residency and fellowship training that a board certified dermatologist who specializes in these procedures has gone through. And we know the skin, we're the skin experts, and this is a skin condition. And so just like with anything else, if you have cancer, you go to an oncologist. If you have a skin condition, you go to a dermatologist. And so I think that we're the best equipped to not only diagnose what's really going on, is this a dimple or this a laxity issue or this just excess fat, and then with our knowledge of technology, be able to address it properly.